Hello everyone. Today we are going to study about the ectopic pregnancy. Let's go with the topic. So at first definition, ectopic pregnancy is defined as the fertilized ovum. Fertilized ovum is implanted or developed outside the normal endometrial cavity. So it is defined as ectopic pregnancy. So for the site of implantation, there is extrauterine and the uterine sites. For the extrauterine, the most common, like 97% of the cases, is tubal ectopic, like tubal site, and in the tubal also ampulla, isthmus, infundibulum, and interstitium or intramural. So ampulla has more chances, isthmus, infundibulum, and the intramural, and the other places are like ovary, abdomen, and for the uterine site, like surgical scar, cervical site, and the cornu. So for the risk factor, so what are the risk factor of the ectopic pregnancy is that history of ectopic pregnancy. If there is one history, like previous history, only one previous history of ectopic pregnancy, then in the next pregnancy there is 50% chance of having pregnancy, and if there is a previous history of two ectopic pregnancy, then 30% chance of having ectopic pregnancy. And the next risk factor is like PID. So if the pelvic inflammatory diseases, like if it affects the fallopian tube, then it can forms like this type of pattern, and then like fertilized ovum gets implanted here and developed, and also this it can disrupt the cilia and the peristalsis movement of the like fallopian tube, so that baby or the like fertilized product of the fertilization will be implanted and they develop in the fallopian tube. So other are like history of surgery of the tubal, history of tubal surgery, so that it can disrupt the normal anatomy of the fallopian tube, and then it can also disrupt the cilia and the peristalsis movement of the fallopian tube. So there is increased chance of the ectopic pregnancy, and history of any abdominal surgery can also be disturbed, like addition of the fallopian tube and other things that can be also occur. And there can be also a failed contraceptive devices, which also has increased chance of the ectopic pregnancy, as like if the IUCD, like copper T, if we place copper T here, then there is like it decreases the like it prevents the fertilization or like implantation and development in the uterus, but it not develop it cannot prevent the implantation and developed in the other part as also. So these can prevent the ectopic pregnancy also. But if there is pregnancy occurring in any IUCD using, then there will be, like if in the normal female, then if there is 9% of the uterine pregnancy, chance of uterine pregnancy, and 1% chance of the ectopic pregnancy, then the IUCD users, if the pregnancy occur, normally there will be less chance of pregnancy occur. If pregnancy occur, then 5 to 7% chance of the having ectopic pregnancy. So people using the women using the IUCD have more chance of having ectopic pregnancy. So these are the risk factor, and other risk factor like smoking and other risk factor can also contribute to formation of the ectopic pregnancy. So for the mode of the termination, like as this product of the conception grow, then there will be the compression of the blood vessel, and then blood vessel cannot supply the whole uh, the product, so there will be the vascular insufficiency. So vascular insufficiency occurring in the baby, and then there can be formation of the mold, and then eruption, and then there will be the abortion, and then there can be rupture. So these are the mode of termination of the ectopic pregnancy. So for the clinical symptoms, as the clinical symptom is mainly amenorrhea, bleeding, and the abdominal pain. So like there will be the bleeding, not because of the rupture, like as already explained about that, there will be the vascular insufficiency, so that like beta hcg will be less secreted, and then the corpus luteum cannot be maintained, and the progesterone will be less, which is maintaining the uterus, although there is not fertilization like an implantation and development in the uterus, but the progesterone which is secreted from the corpus luteum, where the baby outside the uterus, also maintain the uterus lining. And when there is the less progesterone or the decreased progesterone, then the shedding of the decidua causes the bleeding. So bleeding is mainly due to the these condition, not because of the rupture, and the amenorrhea and the abdominal pain also seen in these. And like sign like syncope, there can be like, if there is the rupture, then the patient, all the patient who have rupture does not come with the syncope, but there is chance of having syncope if there is rupture. So we cannot neglect the syncope stage of the patient, so we have to take a detailed history to rule out the ectopic pregnancy if there is any history of the syncope in the pregnancy. And like Collins signs and the Turner signs, like in the center, if there is bluish discoloration, then it is termed as Collins sign. In the Turner sign is in the flank, if there is a bluish discoloration. So this can be due to the blood in the peritoneum. So this sign can be seen. And when we do the PV, then like normal uterus is seen, and the cervical tenderness is also seen. It is also seen in PID. So how like cervical tenderness is seen is that this is the uterus, and this is the pouch of Douglas. So if there is a form like accumulation of the fluid or blood in the this pouch of Douglas, then the cervix, like if we move, then there will be the tenderness, and like irritation of the surrounding structure can also cause these tenderness. And and bogginess, like heavy feeling when we do the PV examination. There can be bogginess in the like pouch of Douglas, posterior fornix. So this can also be seen in the vaginal examination. So for the time of the rupture, like first rupture will be the isthmus ectopic pregnancy. As 4 to 6 weeks it will rupture. And for the chance of like in the ampulla, then 6 to 8 weeks. And for the intramural, then there is chance of 14 to 16 weeks. Why there is increased chance in the increased age in the intramural ectopic pregnancy is that there will be the muscles, uterine muscles, so that it can contract. There can be hyperplasia and the hypertrophy of the muscle, so that it can take the baby, like it can carry the baby for a longer time. And most complication, if the rupture occur, then the intramural pregnancy have more complication after of the rupture. So for the diagnosis, mainly transvaginal sonography is the best choice, is a choice, but laparoscopy is best choice, but normally TBS is done. And we can also check by the beta hcg level, as beta hcg level, if the value is 20, then after the 48 hour, if the value is 1, then it must be double. If it doubles, like if the 20, then it become 40, then it is the intrauterine pregnancy. And if it cannot double, like 25, then it is the chance of ectopic pregnancy. And if it decreases, then the chance of like failing pregnancy. So for the ectopic pregnancy, after the 48 hour, it cannot double. So why it cannot double is that I already explained that um, as there so I will explain here. So as already explained, that if the baby grow much more, then the vascular supply which supplies the baby will be not sufficient. Then like it cannot secrete the enough beta hcg because of the less vascular supply, like vascular insufficiency. So that beta hcg cannot double in the 48 hour, like it takes 5 to 6 days to double. So these parameter can also be considered for checking if the pregnancy is intrauterine or extrauterine or ectopic pregnancy. So other value are like if the beta hcg decreases, then the corpus luteum is not maintained properly, and then there will be the less progesterone secretion. So if the value of the progesterone is greater than 25 value, then it is the value of the like intrauterine pregnancy. And if the value is less than 5, then the it is mainly of the ectopic pregnancy and also the failing pregnancy. So we can do the TBS laparoscopy and beta hcg and progesterone. And the one thing we must know is that the cutoff value, like discriminatory zone of the beta hcg, how much time we have to see the beta hcg level, as if the beta hcg level 1500 international unit, if it crosses the 1500 international unit, then we can see the product, like gestational sac, the product inside the uterus. So if the beta hcg level is greater than 1500, and but there is not seen of the any fetus in the fetus or the product of the conception in the uterus, then we can term it as ectopic pregnancy. Otherwise, if less than this, like less than this, then we can check the double value after the 48 hour of the beta hcg. So this value is the discriminatory zone or value of the beta hcg for diagnosis of the ectopic pregnancy. So for the management of the ruptured ectopic pregnancy, for the ruptured ectopic pregnancy, there is rupture of the fallopian tube. So there is rupture. So first we have to do the resuscitation of the patient, and along with the surgery must be done, not first resuscitation and then surgical, but along with the resuscitation and the surgical, like two bore hole of the intravenous is open and the IV drip will be sent, and like O negative blood group can be given, and after some time, then we can do the ABO typing and give the blood. And for the surgical management, like we have to open the abdomen if laparotomy and laparoscopy, this method. If the patient is in the shock, then we have to do the laparotomy, and if the patient is not in the shock, then we can do the laparoscopy. Then we have to do the like if this is fallopian tube, then we have to clamp here and then cut the fallopian tube, which is called as salpingectomy. We have to do. And what type of salpingectomy is like total salpingectomy is done, because if we cut here like segmental salpingectomy, there is no any use of this left fallopian tube in the future. So total salpingectomy is preferred in the ruptured ectopic pregnancy. So for the management of the unruptured ectopic pregnancy, so there are expectorant management, medical management, and surgical management. So for the expectorant management, as we have to wait and watch to resolve it on its own. So not much thing in the expectorant management. If the like uh, if the product is less than 3 centimeter, then we can do the expectorant management. And if the product is less than 4 centimeter and there is no cardiac activity in the tube, and this value, like we can do the medical management. For the medical management, we can use the methotrexate, which like we have to kill the fetus inside the like tube. So methotrexate is given, and other drug like antimycin, KCl, these can also be given. So in the medical management, this thing can be done. And for the surgical management, if the diameter of the fetus is like 4 centimeter and the cardiac activity is seen, and then we have to do the surgical management. For the surgical management, then we can do like there are salpingotomy and salpingostomy. So stomy means like if like this is the fallopian tube and there is a baby, and then we have to do the linear salpingotomy. And if we do the suture at the site of the incision, then it is termed as salpingotomy. And if we left the site as stoma, like pore like structure in the site, then which is called as salpingostomy. Salpingostomy is more preferred, as if we like if the bleeding, we have to stop the bleeding, and then it will heal in 1 to 2 days, and it is healed by the secondary intention of the healing. And if we do the suturing, then there is chance of having like cilia disrupt and other things. So we have to do the salpingostomy. And these things are in this surgical management of the ectopic pregnancy. So I think these are the thing. Anything left? If anything left, I will be try to cover in the next video. So okay, thank you.